Thank you very much for joining us. My name is Karen Cantwell. I'm a cancer epidemiologist and director of the Daffodil Centre at the University of Sydney and Cancer Council in Australia. And I'm really delighted to have the privilege of facilitating this whole of consortium update for IPaRCS, the International Partnership for Resilience in Cancer Systems. And just to note that I'm calling, I'm dialing in from Gadigal land here in Australia and acknowledging the owners, the traditional owners of the lands on which I'm now standing. I'd also like to acknowledge very gratefully the IPaRCS, all of the IPaRCS consortium members, and particularly the IPaRCS steering group. And I think as we enter what's close to our, well, really conclude probably our third year of operation almost as IPaRCS, it's a great time to reflect on all our activities. And you will remember as consortium members that IPaRCS started as the COVID and Cancer Global Modelling Consortium. We did over the last year rebrand as IPaRCS, and we now are really looking to move forward, not only in terms of still all the work to be done in understanding COVID's long-term impact on cancer systems, but also to really look at how our insights from COVID and disruptions to health systems might actually help countries prepare moving forward to create more resilient cancer systems generally. So today, at this end of year call, we're going to do a few things. We're going to review some of our key highlights recently. We'll be providing updates on some of the commission projects, including projects commissioned by Cancer Research UK, the International Cancer Benchmarking Partnership, and WHO. We're going to give a snapshot on some of the activities from the working groups. And at the end, pending time, we'll have a quick discussion of some of the new opportunities for the consortium, and just a reminder to all members that we're really open to new ideas for projects that the consortium might be able to help coordinate. So this is in the nature of things, and apologies for this, because we only have an hour. This is really quite a didactic format that we use for this meeting. It's really about all the different groups updating everyone on activities, but we do, of course, through the working groups that form over time, look to have much more discussive forum for our project updates. So I'm going to kick off. And before I do, just also a reminder that this is the first of 2 calls. So thank you for joining us. We have 43 participants. We'll be running another call in about 13 hours time for slightly different time zones, but this is, we welcome all the colleagues who have been able to join us today. And also to thank you, because it's really been a consortium that has had quite a high level of engagement and at least 100 regular participants in these calls, which is fantastic. So I'll move on now to just give you a quick update on some of the recent highlights. So this slide kind of gives an overview, and you'll hear a little bit more as we go forward on some of these projects. But first of all, we wanted to welcome Dr. Natalie Fitzgerald from CPAC, the Canadian Partnership Against Cancer, to the IPaRCS steering group. And Natalie is taking the place of Rami Rahal, who has now moved to a different role in New Zealand. And he's very much involved in cancer control in New Zealand now. So we thank Rami very much for his time and his amazing help to IPaRCS and his steering of our direction through time. And welcome on board, Natalie. You'll hear a lot about a lot of work we've been doing in cervical cancer elimination to support low and middle income countries. And we have set up a whole community of practice on this topic, which we'll talk about a little bit later. And we have a new project that's kicked off about really looking at the profile of lung cancer through COVID, and what can we learn from COVID about COVID's impact on cancer systems through this lens, which you'll also hear a little bit more about later. We've also had a major paper accepted at IJC, which has been a truly wonderful whole of consortium effort to really, I think, put out the definitive systematic review on the risk of COVID-19 death for people with pre-existing cancer diagnosis in the pre-COVID vaccination era. And again, you'll hear a little bit more about that as we go forward. So moving on to the next slide. I will now, and I see he's here, hand over to Richard, Prof. Richard Sullivan, who has been a key supporter of our consortium and one of our founders, and really through the task force that he set up, one of the key inspirations for IPaRCS in the first place. I'm going to hand over to Richard for some updates from you, Richard. Thanks.
That's very kind. I'm sorry, I'm a bit croaky. It's slightly early in the morning for me. Lovely to see everybody. Look, a very 5 minutes, very quick highlights. I'm going to start really with the International Treaty on Pandemic Prevention and Preparedness, which, as many of you know, is being negotiated and driven through by the WHO and World Bank Group at the moment, focused on early detection, resilience, response, and also strengthening the international health regulations through a One Health approach. I won't go into the details because they're easy to find. The big issue around this, of course, is the financing. This is something at the moment that's causing a great deal of angst around the world, despite the World Bank Group and the other multilateral development banks being brought in. The actual financing of this particular instrument is still way behind what the ambition was. The World Bank now is being pulled between two different areas. The first is climate change, a huge amount of pressure going on to the World Bank to actually finance climate change and health. And the second, obviously, as I said, is the resilience element of the pandemic treaty. And you'll all be aware, of course, the current economic climate across the globe is very poor, huge inflationary figures. We're also seeing many countries, the bottom 76 countries, simply not increasing their domestic expenditure on health in any shape or form. Worst of all now, the revenues and payments on external debt are outstripping what these countries are actually getting. So their debt to GDP ratio is rising, and that's again creating enormous fiscal challenges. The World Bank now has announced a relationship with the Global Fund to build and strengthen health systems. There is even talk next year of non-communicable diseases being brought more front and center into World Bank Group. Frankly, ladies and gentlemen, I'll believe it when I see it. And by the way, when they say NCDs, they tend to be meaning simple diabetes and simple hypertension. Cancer's often completely left off the radar. But we live in hope, really, that actually the World Bank Group will move into this area. You can imagine at the moment the UN system, including the World Health Organization, is hyper-focused on the issues of conflict, particularly Gaza, the Sudan, less so Ukraine at the moment. And that's taking up an enormous amount of time and effort from these UN agencies. And in particular, as you know, the three pillars of the World Health Organization for cancer, childhood cancers, cervix and breast. Even within the childhood cancer area, there are particular countries they're focused on. At the moment, they're focused on evacuation of children out of Gaza. So the whole ecosystem at the moment, unfortunately, is sort of conflict orientated. In more positive news, I think for 2024, looking forward, there's quite a lot of major commissions being driven. The Moonshot 2 Commission, being led by colleagues in the USA, is focused very much on workforce planning. Particularly in sub-Saharan Africa and Latin America. That's a huge push by the Biden administration. And as you'll be aware of the elections next year, this is maybe one of the last sort of big chances they have to focus on cancer. The Human Crisis in Cancer is a larger commission looking across the whole of the ecosystem, and that will include pandemics. And then there's a major one on omics. For the other partners, I think just want to highlight the IEA's Race for Hope. That will continue at pace, and they're looking to expand that with additional funding. And really just to end on a note of hope here, thanks to the good offices of Julie Terode and also of Mick von Hemmerich on the call today, we've started to really engage with some potential funders for next year in terms of supporting IPaRCS with funding at the meso level to build resilience, pandemic resilience into individual cancer centres as sentinel sites. I won't talk in any more great detail at this moment, Karen, about this because it's still at an early stage, but there's an idea here that what we can do is say to funders, look, in order to build a resilience network to support IPaRCS, you need to support specific development in terms of clinical informatics, data collection, etc., and also sample collection within individual satellite sentinels across the globe. And that's the broad idea here. So we're trying to use this wave of pandemic funding and preparedness to move forward. And that is my 5 minutes up. So thank you very much, Karen. Back to you.
Oh, that's absolutely brilliant. Thank you so much, Richard. A very thought-provoking 5 minutes. And I will say, look, I think as all of you on the call will know, IPaRCS is still a coalition of the willing, essentially. And we have, you'll hear about the funded projects, but they've been very targeted projects. IPaRCS as a consortium actually doesn't have centralized funding. And I think what you and Julie Tarot are doing, Richard, in terms of thinking about a sentinel site network that will provide important data to facilitate IPaRCS work going forward, and to facilitate the key policy relevant research that we might be able to do is absolutely critical. I think you've also given us food for thought in terms of what role we might be able to play, in terms of contributing to the questions around health systems in conflict zones, and potentially as well thinking about Moonshot 2 and what that might open up for us. So thank you so much. I'm so sorry that we don't have time to open up the discussion yet, but if there's time at the end, I'm sure there'd be lots of questions and thoughts for you, Richard, as we go forward. Thanks. So I'm going to go now, we're going to go to the teams working directly on the commission projects. And I'm down here, but really all I'm doing is introducing introducing the different projects. So the first is to give you an update on the Cancer Research UK funded program of work around developing a major tool to support cervical cancer elimination planning, particularly for LMICs. And this is a collaborative project between IARC, the Daffodil Centre, and IPaRCS, supported by Cancer Research UK. And I'm going to hand over to Danny Rivas, who's going to tell you about this tool, and then we'll tell you a little bit about where we're up to with its rollout. Thank you very much. Over to you, Danny.
Thank you, Karen. Yes. So as Karen said, this project has been funded by CR UK support. So in September 2021, Cancer Research UK has generously agreed to support the Daffodil Centre and IARC in the development of the elimination planning tool, with the aim for the tool to be utilized by policymakers and advocates to better understand how to mitigate the impact of COVID-19 on global cervical cancer elimination. So this aligns with CR UK's goal in supporting researchers and research organizations to drive policy change and improving equitable access to HPV vaccines for girls within low and middle income countries, specifically with the aim to prevent cervical cancer. So although the initial focus was on addressing the impact of COVID-19 as the situation with the pandemic evolved, the project also evolved to capture the fact that many countries before now have been unable to launch their elimination strategies. And so the tool now explores, with a later start date than original model, how the different pillars of the strategy and different interventions could interact with each other to ensure each country still achieves the 90-70-90 targets, and then ultimately the elimination of cervical cancer. So ultimately, the EPT is going to be a brilliant visualization tool and accompanying briefings, which will sit on IARC's Global Observatory platform, and it will be freely accessible to anyone who wishes to use it, especially civil society and policymakers, to inform their national approach to achieve cervical cancer elimination. So as you can see, the development of the elimination planning tool has been a collaborative effort with an expert team involving people from the Daffodil Centre, IARC, King's College London, and Cancer Research UK. So the objective of the EPT is to create an interactive tool to help policymakers and stakeholders to plan their cervical cancer elimination programs for their country or region. So to do this, they will be able to look at different goals for the 3 elimination pillars, and not just the 90-70-90 targets set by the WHO, but also at different implementation years and alternative strategies that might be more achievable in the short or even the long term. The user interface of the tool is being developed by IARC, and it will allow users to select different scenarios and regions or countries of interest. The underlying data that goes into a tool is based on predictions from our Policy One Service model. The main inputs that will go into the tool are the different coverages of the 3 pillars at different times, and users will also have the opportunity to select what we call potential accelerators. For example, extending multi-age vaccination up to age 25, or even including the vaccination of boys. Then the outputs can be divided into three parts. First, there's the impact outputs, which include cervical cancer incidence and deaths averted, and the projected year of elimination when cervical cancer incidence would really reduce to below 4 cases per 100,000 women. And then the tool will also provide an estimation of resources needed for implementation. And finally, we will have economic indicators such as return on investment, budget for different time frames, and which will be very useful for policymakers to plan their elimination strategy. So this is a preliminary version of how the tool will look like on IARCS Global Cancer Observatory website. So on the left-hand side, you will have the different inputs, and the outputs will be on the right. So as you change the inputs, the outputs will be updated on the screen to reflect the new conditions. So in the inputs, you will be able to select a specific country and the start year, and then you can select the starting coverages, as well as a short, medium, and long-term targets for the 3 pillars. And then in the outputs, you will find the estimated elimination year, your return on investment, and budget impacts over the first 5 or 10 years of implementation. And then you will see 2 different graphics. So on the left, the cervical cancer incidence over time with a straight line representing elimination threshold. So when the incident crosses this threshold is when elimination has been achieved. And then on the right, you will find the cumulative number of lives saved over the century with snapshots over the next 30, 50, and 100 years. So additional to the outputs presented previously, users will be able to download a top-level report, which will summarize some of the key scenarios and outputs for a specific country, as well as data on coverage and burden of disease. This document, which we have named Country Brief, will look something similar to the image shown on the right, and it will provide valuable information to policymakers and stakeholders to assist the planning of the cervical cancer elimination strategy in their country. So these are some preliminary results for Vanuatu if their elimination strategy is implemented on different years. So on the left-hand side, you can see the cervical cancer incidence over time compared to the elimination threshold. So as you can see how it varies depending on the start year of the strategy. And then on the right-hand side, you can see how the variation of the start year can impact the number of lives you can save over the century. Thank you.
Thanks so much, Danny. And so Danny's told you about the technical development of the tool, and we are aiming to have it ready and to be launched early next year at this point. But I also want to just spend a minute or two telling you about the work that we're doing to facilitate the actual use of the tool to inform planning and economic evaluation and putting together the funding case for elimination in LMIC. So we have set up a IPaRCS facilitated EPT community of practice, and this aims to bring together the very many stakeholders that are very interested in this tool. There has been a lot of interest through networks, through advocacy networks, and through the various contact points with the team. It aims to foster collaboration and knowledge transfer between the technical teams and users of the EPT, and we are running quarterly meetings. Like this meeting, there will be 2 meetings every time to accommodate different time zones. So one of the things we wanted to let you know is that if you're interested in joining this community of practice to work through the use of the tool, there's the contact detail there for Amy Pagotto, who is running that, the secretariat for that group. And just to say that on the right, I won't go through the details, but there is a semi-structured process that we're using to help the tool really well, to help, I guess, to support countries in engaging with the predictions and using the tool to help to build the business case. So it really, really starts with structured consultations with community, clinical healthcare workers, civil society and government policy makers to identify the key policy questions and needs within the countries. And then we've identified various steps going forward involving the collaborative co-development and deployment of the tool, that will assist the country in planning for elimination. If I just move on to the next slide, the other thing that we wanted to let you know is that we have recently put in a funding request. So we did put in a proposal. It's Africa-led in response to a call from the Bill and Melinda Gates Foundation on a funding opportunity for strengthening health and disease modelling for public health decision making in Africa. And so this is an application led by Dr. Mulliken Gizau in Ethiopia, and it's really all around using the EPT to inform cervical cancer elimination decision making in Africa. And we put in a project which would allow funding for up to 1 million. The short story about this project is that it will potentially fund capacity building and planning activities in 5 African countries: Ghana, Ethiopia, Tanzania, Kenya, and Nigeria. And we hope that the outcomes would also be relevant to other high burden LMIC countries. So just moving on to the next slide, we also just wanted to quickly let you know that the tool is a key part of some now funded programs of work which are being run out of Australia to support countries in the Western and Indo-Pacific. The first is a program called Elimination of Cervical Cancer in the Western Pacific, which is philanthropically funded by the Minderoo Foundation. And this is a picture taken just a few weeks ago showing the launch of the cervical cancer elimination program in Vanuatu as a sustainable program, which has been supported by discussions around the economic and health impact case for elimination, assisted by the type of modelling projections that you saw earlier. And really happy to also tell you that a week ago on November 17th, Cervical Cancer Elimination Day, we just move to the next slide, the Australian government has announced a major expansion of this to what's called now the Elimination Partnership in the Indo-Pacific for Cervical Cancer, or EPIC, which will take these activities to at least 8 further countries in the Indo-Pacific region. And again, the elimination planning tool will be a key part of it. And this slide just illustrates the various areas in which EPIC will act, but the 6th priority is really the one that's been facilitated through IPaRCS. It's policy modelling support and sustainable financing for countries considering initiating cervical cancer elimination initiatives. So with that, I'm going to move forward, and I'm delighted we'll change track now and we'll move to an update on a completely different project. This is our WHO commissioned systematic reviews on COVID-19 and cancer. So some wonderful news to hear about here. So I'm going to hand over now to Associate Professor Julia Steinberg. Thanks, Julia.
Thank you very much, Karen, and apologies for my technical difficulties as well. So really this work on the risk of COVID-19 related death for people with cancer follows some fantastic discussions with Andrea Barbie and Philippa Rotbeck at the WHO, as well as some work that we have done previously. Next slide, please. And I right from the start want to highlight that this review, as well as the 2 others, were really only possible thanks to so many fantastic collaborators in this consortium who have made huge contributions throughout all the screening of thousands and thousands of abstracts and titles. You've just seen the numbers from Rita's reviews, and I'll show you the one from the COVID death and cancer review in a second. And we are just incredibly grateful to everyone who's made it possible to complete this work. So for the review on risk of COVID-19 related death for people with cancer, as mentioned, we built on previous studies and really concentrated here on higher quality studies for the pre-COVID-19 vaccination period. So we wanted to consolidate estimates that were adjusted for at least age and sex, and that also explicitly focused on recent cancer diagnoses and The time since cancer diagnosis and treatment was something of particular interest to us, so I'll tell you a bit more about that in the following as well. We've completed a large number of analyses stratified by different populations, as well as effect estimates, and also consolidated estimates for specific cancer types, as well as metastatic and non-metastatic cancers where they were available. Next slide, please. So as mentioned, and as you can imagine, there have been thousands upon thousands of studies in the area of COVID-19 and cancer. So we completed an initial search in December 2021 with over 17,000 unique title abstract records identified. We then further completed a search update in May of this year with several more thousand records. So that in total, the collaborative team reviewed close to 24,000 unique title abstract records with ultimately 33 studies included in the quantitative synthesis in this work. Next slide, please. So what did we find? Across all cancers together, studies consistently found a higher risk of COVID-19 related death for people with recent cancer diagnosis or treatment compared to those without. And I'll tell you a bit more about results by time since diagnosis or treatment in the following. Evidence also suggested that risks were particularly elevated for metastatic cancers compared to non-metastatic cancers, with risk estimates non-overlapping on studies of hospital inpatients with COVID-19 in particular. Next slide, please. We consolidated estimates for over 30 different cancer types, and the two standout results were very consistent evidence on elevated risk of COVID-19 related death for people with hematological cancers, as well as with lung cancers, as shown here with adjusted hazard ratio and odds ratio estimates of 2.1 to 2.8 for hematological and 3.4 to 4 for lung cancers. There was also some evidence for elevated risks for liver and pancreatic cancers, but only one study having looked at those. There was some mixed evidence for breast, colorectal, and prostate cancers. So quite a few studies of these cancers found elevated risks for recent diagnosis or treatment, with at least one other study with not finding such a significant result. Of course, there could be some reasons for this disparity in findings, in particular, for example, how individuals were ascertained and included, as well as the quality of some of these studies. We have a paper in press on this work, as Karen mentioned before as well. So if you are interested, we would invite you to read the details once that is published. So the conclusions of our review were that there was an elevated risk of COVID-19 related death for people with recent cancer in the periods prior to COVID-19 vaccination, with risk depending on cancer type as well as time since diagnosis and treatment, and cancer stage as well, particularly elevated risk for metastatic cancers. But of course, even this review is only a very high level overview of the available evidence. And so based on what we could see from the original and primary studies, quite a bit more research would be needed to disentangle how the risks depend on key characteristics such as age, sex, but also cancer type, stage, and various other characteristics, as well as, of course, changes that occurred with COVID-19 vaccination and with the prevalence of different virus variants as well. We hope our work can provide a benchmark to inform future comparisons and really support evidence-based decision-making going forward as well. Thank you very much again for the fantastic team who contributed to this.
And thank you very much, Julia. It really was truly a whole of consortium effort. It just incredible participation from so many countries on this project. And thanks to you for leading it, Julia. Okay, Richa, I believe you're back. Are you here with us?
Hi again. I'm sorry for being disconnected.
No problem.
I'm back.
So
can we
can
on?
pick up. Yes, you can pick up where you left off, if
Yes.
that's okay.
Yes, thank you so much. The next slide. Yes, thank you. So back to this slide. So as you can notice from this slide that the reduction cancer services were present in all HDI groups, especially in the medium HDI groups, where the reductions in cancer care services were the highest. But globally, the reductions were for screening, it was 39%. For diagnosis of cancers, it was 23%. For diagnostic procedures, it was 24%. And for treatment, it was 28%. While talking about treatment, the reductions range from 15% for radiotherapies to 35% for systemic therapies. Next slide, please. And this chart shows the reductions in cancer care services by regions or continents. So as you can see here, the highest reductions were present in Africa, where it was almost 56% of reductions in diagnosis, in overall treatment. And for Americas, it was 24%, and Asia was 37% in overall treatment. What you can notice from these two slides are that we don't have representation from low HDI countries where the data from where it was very scarce. And also from African region, we only had 2 countries in our study. Next slide, please. And this particular slide shows our results from our mitigation scoping review. So basically what we did for this study was we grouped the studies or the data into 4 functions of the health system performance assessment from WHO. And we divided the data into governance, service delivery governance, resource generation, and financing. And what you see on the slides are the most commonly reported results. So for the first one, infection control, the most commonly used strategies for mitigation control for mitigations were compulsory use of masks, social distancing in wards and waiting areas, regular disinfection, PPE worn by healthcare providers, and patients tested for COVID-19 before admission into the hospital. For human resources management, we saw that many hospitals created COVID units and also had dedicated staff for COVID care. The clinical and non-clinical staff were separated, and the surgical and oncology staff were not involved in COVID care. Additionally, the duty hours were modified for the healthcare providers to avoid cross-contamination between them. As for screening and diagnostic tests, we saw a big shift to use of telehealth, and there was extensive use of SMS and phone for screening invitations. There were a lot of teleconsultations. In case of skin cancers, some clinics and hospitals preferred sending photos of skin lesions. And also for follow-up, patients were sent SMS reminders. As for treatment, we saw that a lot of hospitals and care centers, they modified their cancer treatment regimens. Oral drugs were preferred over intravenous chemotherapy to avoid the risk of COVID infection. And if possible, radiotherapy sessions were postponed and only performed in high-risk cancers. Similarly, hyperfractionated radiotherapy was preferred over other treatments. And the intervals between 2 treatments were increased or made larger. So for the mitigation scoping review, among the 30 studies that we included, 17 studies showed that actually after implementing the mitigation strategies, the number of people who received health services actually increased. But since this was a scoping review, we did not evaluate the risk of bias or other factors of the included studies. So yeah, that's all from my side. Thank you very much. And thank you again to all the co-authors who gave so much time and effort for these 2 reviews. Thank you very much.
Thank you so much, Richa, and thanks, Julia. And also thank you to Andre Elbawi, who I believe has joined us and really was the instigator of these important studies via the WHO work that he's leading. So thank you, Andre and all. So very complimentary. You've just heard about systematic reviews of the peer review literature. But as you might recall, IPaRCS has also been engaged on a number of other methodological approaches under the aegis of the International Cancer Benchmarking Partnership, also aiming to understand the impact of the crisis on cancer systems. So to introduce us to the ICBP work, I'm going to ask Harriet Hall to give us an overview of these projects. Thanks, Harriet.
Hello, thank you, Karen, and for the team as well for inviting me to introduce the work this morning. As per Richard, it is a bit early for me as well, so hopefully the coffee has kicked in now and I do make sense. Apologies to those of you who've seen this slide before, but I thought it would be useful to do a very quick overview of the ICBP. So fundamentally, we are a partnership which commissions benchmark work and benchmark studies to look at international variation in cancer survival and outcomes. We then commission exploratory research to try and understand the factors that are contributing to variation. We do this to generate evidence for policy and practice change and fundamentally improve patient outcomes. We're made up of high-income countries that have population-based cancer registries, similar spend on healthcare, and universal access to healthcare, and that allows us to make the kind of comparisons that we do. We limit our scope through a focus on cancer sites that are relatively common, hard to treat, experience significant variation, and contribute to the overall burden of disease in high-income countries. Next slide, please. Following the pandemic, we realised we were in a really good position to undertake some research to try and understand the impact of COVID-19 on different aspects of cancer control and mitigation strategies in our jurisdictions. We commissioned 2 pieces of research, one quantitative approach through IPaRCS with Isabel Soa-Jamataram as the lead, and one for the Daffodil Centre with Karen as the lead. We wanted to both quantify the impact on cancer outcomes as well as to collate and explore the impact on health systems and policy changes. We hoped in doing this that the analysis would enable us to learn and share learning about the different mitigation approaches and support jurisdictions in their recovery efforts, as well as informing future approaches to cancer service planning when faced with significant disruptions in the future. And I'll leave it there and hand back over to the team. Thank you.
Thanks so much, Harriet. Well, we're going to hand now to Isabel, who's going to take us through the quantitative piece. Isabel, are you online? I know she was joining us.
Hello, Karen.
Oh,
It's
hi.
Eileen here. Can you hear me?
Okay, yes. You're going to take this
Hi.
one? Great.
Yes, thank you. It's great to see you and everybody else on the call. I would just like to send my apologies to Isabel. She already has another obligation that she couldn't join for this morning or this afternoon, wherever you are. So I'm Eileen. I'm a scientist at IPaRCS working with Isabel and the team on the impact of COVID on cancer, and Harriet gave a really nice overview of the ICBP work and the aims that we have been looking at in terms of the quantitative side, which I'll go into a bit more detail now. As has been mentioned in previous presentations, there's been a number of teams involved in this collaboration, and really it wouldn't have gotten to where it was without the teams involved. And I'm going to present some of the work that we've done from the IPaRCS side. Thank you. So I'm just going to provide some summary results really to describe what we've been seeing and what we've looked at. Really what we've done is looked at the impact of COVID on cancer diagnosis and cancer incidence using the jurisdictions that submitted to the ICBP project. So what you can see here, I've had to anonymize the jurisdictions involved so that this is what each of the different figures represents. And this is just for permissions purposes. And the figures really show the red line is the predicted incidence rates that we would have expected to see in 2020. And the blue line then represents the observed incidence rates and what we've really seen. The blue shaded area of each graph then also represents the first 4 months of the pandemic lockdown. So I'm presenting here breast cancer. So I thought this was a good one to present because what we've really seen significant drops in the expected number of cases in 2020. And this also varies across the different jurisdictions. You can see that so the top line where you see 26% decrease, 34% decrease, This represents the decrease in the number of cases in the first 4 months of the lockdown. The second row then represents the overall decrease in the entire year of 2020, and that's why that's a little smaller. So we can see in the first 4 months of lockdown, that's where really the largest decreases were observed. And it does vary across the jurisdictions. We see as high as 37% decrease in jurisdiction J, and then some other jurisdictions showing much lower decreases, yet it still does appear to be quite a marked reduction in the number of cases. The 2020 overall decrease then is much smaller than the first 4 months of lockdown, and we do see from the blue line that after those 4 months there is some catch-up period for breast cancer, and we do expect this to be really related to the impact of screening and the way that breast cancer is diagnosed in each of the jurisdictions. And it's really interesting to then see how and discuss with the different collaborators the differences in how cancer services were impacted at jurisdiction level, and then see that from the data here. So the next slide then I've just presented just to juxtapose against the breast cancer is the impact on lung cancer diagnosis. And what we see is something a little different. So it's not as large in terms of the decrease in the number of expected cases that we observed in 2020. Even in some jurisdictions, there's little or no reduction if we look at the age standardized rates. And we do expect then that this is most likely because of the way lung cancer is diagnosed, the way it presents, and also how the symptoms as well across the different cancer sites play a role. So there is much, if we remember, breast cancer was around 30% reduction in a lot of jurisdictions, whereas lung cancer, it's much, much lower. We're seeing only as high as 18%, which is still some type of reduction, but again, it's not as marked as breast cancer or other cancers that are of screen detected. So I'll just go to the next slide then. Oh, sorry, thanks. So just to provide a summary, that was a quick stop around a couple of the main cancer sites, but really what we're seeing in a number of the cancer sites is a reduced reduction in the cancer cases that are being diagnosed on a month-to-month basis in the year of 2020. But we are seeing a lot of variation on cancer sites and across the jurisdictions, which has been really informative for us and for those jurisdictions. We're also seeing differences across the age groups of diagnosis, and we're looking into that as well further, looking at the impact on older cancer patients compared to younger cancer patients. There are also investigations ongoing in terms of whether there's been a stage shift in diagnosis. And we have seen for some cancer sites, there has been a slight shift in the diagnosis of cancer from earlier stages to late stages. So we'll also be including those results in the upcoming manuscript. In terms of the impact of COVID in 2020, we're seeing this to be a really, really strong impact, particularly in the first 4 months of the lockdown. Yet the difference in the magnitude and the length of the impact as well is something that we really want to highlight. We do see some jurisdictions recovering much, much quicker than others, and also some jurisdictions still not showing catch up in terms of the cancer diagnoses. We haven't looked at 2021, and there have been a lot of discussions, especially with Australia and New Zealand, about how the impact of COVID happened at different times, and perhaps there was a delayed impact. So it might look better in some jurisdictions, but it could be that the impact has yet to be shown. So that's something as well that we're really aware of. In terms of the impact on mortality and survival, at the moment, we haven't seen as much impact on survival, but we still are looking into this in a lot more detail. These results are really more reflective of the incidence and diagnosis of cancer, but it is something that we want to really look into, is the resilience of the health systems during the pandemic and also after. We also aren't able to include jurisdictions from low and middle income settings, which is something that perhaps should be considered as well. So I'd like to thank everybody for listening and for everybody involved in this project.
Thanks so much, Eileen. And I think this is just a phenomenal data analysis that we've really been wanting to see as IPaRCS right from the beginning. It really gives that picture. Sitting alongside of this, as Harriet said, there's another piece of work that's really, I think, helping form the narrative around what you've just shown us in terms of the quantitative data. And this is the qualitative review of health system and policy responses. Karen Chiam is going to take you through a quick summary of this piece of work. But just before you start, Karen, I will flag that we're not on track to finish on time. So what we'll be trying to do, I think, is to do the main work updates and then have a quick call out for new project ideas on the hour. And then those of you who can and would like to stay, I hope that we can extend the time a little to do the specific working group updates from the breast working group, breast screening working group, and the cervical working group for high income countries. So we may rearrange ourselves that way in case people need to leave on the hour. So Karen, sorry to put pressure on, but I might ask you to also keep it fairly short as you go through this work. Thanks.
Yeah, sure. Thanks, Karen. Hi, everyone. My name is Karen Chiam, and I'm from the Daffodil Center. So for this mixed methods project, our aim was to collect information on the impact of the pandemic on the health system and clinical policy changes across the 12 ICBP jurisdictions on cancer care. And we've done this using two main approaches. Firstly, through the desktop review of grey literature, and secondly, through qualitative survey and stakeholder interviews to explore the overall impact on cancer services, but also on very specific cancer service areas in exemplar jurisdictions through the 3 case study topics described in the bottom box below here. So for the case study topics and exemplar jurisdictions, they were selected based on the criteria listed in the gray box on the right. But perhaps we'll skip the description today. So next slide, please. Just very quickly, one of the important criteria for the selection and also for the interpretation of the data was the consideration of the lockdown stringency implemented across the jurisdictions during the pandemic. And for this study, we've used the Oxford Stringency Index shown in the graph here, where the high stringency index is represented by the yellow color, and the more relaxed stringency index are represented by the blue color. So overall, this graph demonstrates the changes and variation of the stringency index across the jurisdictions over time, which is a very important thing to consider when we interpret the data. Next slide, please. So at the last consortium meeting, we have provided some snapshots of our grey literature finding, focusing on the cancer screening and cancer treatment disruptions in some jurisdictions. So since then, we have completed most of the data synthesis for the grey literature component for most of the ICBP jurisdictions. So for today, I just want to give a very quick follow-up on this work. Next slide, please. So this is an example infographic that really summarizes very a tip of the iceberg of the information that we found with the grey literature information, focusing on what the common disruptions, mitigations, and gaps in knowledge are across the 4 UK jurisdictions as an example. So in 2020, all 4 UK jurisdictions experienced a significant disruptions in their national cancer screening programs, as well as their elective surgery services. And in fact, the elective surgeries continue to experience ongoing challenge, along with the workforce shortage in all of the UK jurisdictions following 2020. There were also many common mitigation strategies identified, such as the prioritization of urgent or high-risk individuals and change in models of care, which pretty much is what Richa has kind of presented in systematic review as well. They pretty much aligned with one of the key findings of the systematic review, so I will skip that as well. What I want to highlight here is there is some challenge in this grey literature finding, and that is the lack of proper evaluation study and information to conclude how effective some of the mitigation strategies are for each of the jurisdictions due to I guess like no grey literature finding in this space at the moment in time. Next slide, please. So, sorry, yeah. So I guess, can we go back to the one slide? Yeah. So going back to the gaps that I've mentioned, this is where we hope that the qualitative interview findings can complement and support the grey literature findings through the stakeholders interviews to explore the perspectives of the effectiveness of some of the mitigation strategies as an example. So today, what I've done is I've selected some of the key findings from the stakeholder interviews across 10 out of the 12 jurisdictions findings that we have, focusing on the common experiences on the impact of the pandemic across the 3 different time points that I'm going to show in the next 3 slides. Next slide, please. So like Eileen, the individual alphabets represent the individual jurisdictions. So in 2020, the common discussion topics were focused on cancer screening disruptions again, and the prioritizing of services, which supports our grey literature findings. However, most of the stakeholders also identify early PPE shortages as a significant challenge during this time. Staff redeployment and centralized decision-making were common key mitigation strategies that were implemented across the majority of the ICPP jurisdictions as well. Next slide. In 2021, the perceived impact of the pandemic has shifted to issues focusing more on wait times, backlog, and workforce shortage for many of the jurisdictions. And perhaps not surprisingly, the topic on the feeling of burnout among the healthcare workers was quite substantially discussed as well. A key event and a significant mitigation strategy implemented during 2021 was the availability and role of the COVID vaccine, and that has significantly changed the course of actions and behavior in 2021 compared to 2020. Next slide, please. So this is the last phase of the period of time that we've investigated in 2022. The burnout of the workforce remained a significant and common challenge among the jurisdictions, and the discussion topics were dominated by reflection on what are the lessons learned, including the reflections on what actions and strategies has worked or not worked during the pandemic in each of the jurisdictions. So to give you an example, the common reflections include the perspectives of for the need to rationalize decisions more, providing better support for workforce, and facilitating transparent and effective communication, which include the appropriate messaging to the public during the pandemic. So most importantly, based on the stakeholder interviews findings, it is also clear to us that a single mitigation strategy does not always work the same way across different settings, for instance, like different cancer service areas and in different jurisdictions as well. Next slide, please. So a very quick conclusion slide. The overall general interview findings highlight the common and contrasting features arising across the 3 different time points and across the 10 different jurisdictions. It has definitely helped us to identify additional insights to certain cancer care areas or topics where the grey literature information was not available at the moment. So at this current stage in mind, we are towards the end stage of the project where we are writing up and finalizing a lot of our grey literature and qualitative reports. So hopefully I'll get a chance to share more details in the next consortium meeting with all of you.
Thank you so much, Karen, Eileen, and Harriet. Really appreciate that. I do know we are over time, and I know our European and Northern Hemisphere colleagues may need to leave to get on with their day. So for those of you that do need to leave, we just did want to say before you go, IPaRCS is always open to suggestions for new and emerging ideas where we can play a role to help with policy or decision-making support for leaders in cancer control. And just to mention that we do have always a number of discussions on the boil about what the next projects might be. You'll hear about one of the new projects in a minute, the multi-cancer lung cancer working group work, for example, but there are also current discussions around quantifying the relative impact of cervical cancer elimination on other gynae cancers and their relative importance and interventions in that space. There's also discussion around a project being led by Ferle Coupe and Eleonora Filetto around looking more specifically around the role of bowel screening in middle income countries. And there's always other ideas floating around. So just a general call for all of you, if you do have thoughts about how we could play a role in any space around increasing the resilience of cancer systems, please feel free to contact the Secretariat at the email here. So for those of you that can stay, we will roll on, and thank you very much. I think we will tweak our presentation timings for tomorrow's session, but thank you very much to all our presenters. So for those that can stay, we also have some fantastic project updates still to come. So I'm going to hand over next to Dr. Preston No, who is going to talk about the multi-cancer lung cancer working group. Over to you, Preston.
Thank you, Karen. So I'm going to try and be very quick because this is more of a call for expression of interest. But this is a piece of work that is focusing on the impact of the pandemic on lung cancer. And the overall goal that we're working towards is examining more critically the feasibility of COVID as using COVID as a natural experiment on cancer screening. The idea being that the disruptions that we saw allowed us to see what happens when you delay diagnosis. The problem with this is, of course, there are many known problems and known unknowns around cancer data systems and cause-death attribution. And so this might actually not be a feasible thing. And so lung cancer is actually a good control in this regard, in that screening is not implemented on a wide scale. And so there's not likely to be any overdiagnosis. And so if we could just look at the data real quick. So what we found across the jurisdictions that provided data for us is that there was a noticeable impact in some countries, notably in the Netherlands. There was an increase in stage 4 diagnoses in 2021, and there was a decrease in lung cancer surgery in Canada. And so both of these would imply some increase in lung cancer mortality, which is not what we found. And so this kind of casts doubt on the idea of using COVID as a natural experiment, but the data that we have is admittedly thin. So if we could just go to the next slide. And so I guess we're looking for anybody who has any data that can help us answer this question. We're very interested in having a chat with you. So yeah, before I hand over to the next person, I'd just like to thank the people on the screen right now. But yeah, thank you very much.
Thanks, Preston. And just to say, I think there's still a big piece of work that we all need to kind of bring together around the type of incidence disruptions that you saw from the IARC team, and how this might impact mortality for different cancers in the intermediate and longer term. And in the settings we've been looking at, it is, as Preston's alluded to, a very mixed and somewhat confusing picture. And I don't think it's all clear yet whether there will be substantial long-term mortality implications in all countries, and to what extent there will be country differentials in mortality. So that's, I think, the current focus of your work, Preston, and the Lung Cancer Working Group. Thank you very much. It's something to be dived into further. So for those of you still with us, we've still got a core here. We're going to go next to the breast screening project working group and over to Janine Figueroa. So Janine, lovely to see you, and over to you on what's been going on in the working group. Thanks.
Thanks so much, Karen. And thanks for the opportunity to present on behalf of my colleagues. So Kaz and the team led at the Daffodil Center are really looking at using modeling data, but now actual real world data to understand how mammography screening is impacting diagnoses and hopefully other outcomes. And so currently they're using data from Denmark and Australia, but we are hopefully looking to expand this out to other countries where data might be available to compare how screening over time and hopefully in the future is impacting cancer outcomes, specifically focused on breast cancer. Next slide. And specific questions is how screening participants change. So obviously you've heard a lot of information from various different cancer sites in various reviews and systematic analyses. But now we need to drill down into more detail about specific patient populations that might be impacted so that we can hopefully improve outcomes. And so these are many of the different questions, and I know we're really out of time. But we also are looking to, next slide, please just highlight that we've had some recent publications on behalf of the consortium published in eLife that hopefully people will be able to look at in their spare time. Cheers, thanks so much.
Thanks so much, Janine, and I'm so sorry about the time crunch. We will we'll revise it for tomorrow. I will just go on very quickly to give you a quick update on behalf of the cervical screening working group for high-income countries. You've already heard earlier, there's a huge amount of IPaRCS activity around supporting low and middle-income countries. But really what we wanted to do was really announce that at this point, unless people have particular areas of interest that they would like to put forward, that we're going to put into hibernation, let's say, the cervical high-income country working group, because they have done several key pieces of work that you see on the screen, and I think have really pushed through to some of the key insights around minimizing the impact of disruptions in cervical screening, which is shown on the right. So I think that's been a very coherent, fantastic piece of work from that group, and I'd like to thank Megan Smith and Emily Berger and all of those involved in the high income work for IPaRCS. We do see IPaRCS as a very responsive and dynamic consortium where project teams will potentially spring up, do a project or program of work, and then perhaps go fallow again in response to the needs all the time. So we'd just like to sort of thank, I think, our high income cervical group and really let you know that for the moment we will disband this group until the needs become pressing again. So with that, I would like to, very over time, 10, 11 minutes over time, thank you for your patience. For those of you joining tomorrow, really looking forward to seeing you again. And thank you to all of the presenters and to all of you for being part of this amazing consortium. Thanks, everybody. Bye.